Ochanomizu, Tokyo, is home to Juntendo University. The university has grown along with the development of modern medicine in Japan. The Japan Medical Education History Museum is located in a corner of this institution that still produces many doctors.
UHC を実現するためには3つの要素が必要です。一つはコスト、安い費用で、そして誰でも簡単に気軽に医療を受けられる、そして3つ目、高い質。この3つを共に実現するのはとても難しいことですが、日本はこの3つを合わせて実現している非常に珍しい例だと言えます。そのおかげで日本は戦後から医療を改善して現在では、世界で最も長寿な国を安い費用で実現できています。医学教育の制度を実現するために日本は明治時代になって西洋医学を取り入れて、そこから現在に至るまで長い紆余曲折の歴史がありました。
Essential for achieving universal health coverage, or UHC, is medical education that enhances the quality and quantity of medical care. Let's explore the history that has enabled medical education in Japan to develop in a way that makes UHC possible. Japan's first encounter with Western medicine dates back to the 16th century. Portuguese missionaries visited Japan to spread their religion, and also brought with them Western medicine, which was very strange to Japan at the time. The Edo Shogunate was established early in the 17th century. This feudal society, with a strong centralized political structure, endured for 265 years. This was a relatively peaceful period, during which traditional medicine originating from China and further developed in Japan became widely used.
現在の日本の医療の世界的な特色っていうのは広くあまねく医療が行き当たっていることだと思うんですけれど、それは江戸時代から始まっているわけですね。で、江戸時代にはどういう形で医療が広まったかというと、売薬という形でね、広く広まる。どこの村に行っても置き薬っていうのがありましてね、医者がいなくても自分で治療するというような形で医療が行き当たってたわけですね。
At the time, the Edo Shogunate had a policy that managed and restricted exchanges with foreign countries. Contact with the West was limited to Holland, and only in Nagasaki, which was far from the central government. The medical knowledge brought by Dutch merchants attracted the interest of doctors of traditional Chinese medicine in Japan, who were quite passionate about new techniques. What attracted particular attention was the study of anatomy, which was developing in Western medicine at the time. That momentum was accelerated by a translation of Kaitai Shinsho, a new text on anatomy brought from Holland in the 18th century. From about the mid-18th century, a form of medicine called Kandan Setsu that combined traditional Kampo and Dutch medicine was widely practiced. On the other hand, the training of medical practitioners at the time was based on an apprenticeship system. Those who aspired to become a doctor trained as an apprentice under a local senior, then studied under a noted doctor in an advanced region, received a diploma, and commenced practice. There was no uniform training system for doctors, and the time had not yet come for improving the quality and quantity of medicine nationally.
日本の江戸時代の医学というのはやっぱり特筆すべきものがありました。多くの国民が、文字が読めて学識が高い、しかも知的な好奇心が非常に高いということで、医者の数もそれから出版されている医学書の数も、日本は極めて多いんです。量的にもまた質的にも高いレベルを持っていた日本の医師たちがあったからこそ、江戸時代が終わってですね、明治になって西洋医学を取り入れようとした時に、急速に、それを取り入れて広めることができたわけです。
In the 19th century, Western countries reached out to East Asia to acquire new colonies. Japan had restricted exchange with foreign countries, but with the frequent appearance of foreign ships in coastal waters, opinions wavered between strengthening such restrictions or broadening the interaction. At this time, there were conspicuous moves to enhance the quality of medical care in Japan. Tekijuku in Osaka and Juntendo in Sakura, Chiba, nurtured many students as private schools teaching Western learning in medicine brought from Holland. Juntendo also performed surgical techniques which did not exist in traditional Chinese medicine. In 1857, the Shogunate formally invited doctors from Holland. In Nagasaki, modern Western medicine was taught for the first time by the naval surgeon J.L.C. Pompey van Meerdervoort, known as Pompey. Pompey taught modern medicine that had commenced in Europe at the time. He divided teaching between basic and clinical medicine, and also performed the first human dissection for the purpose of medical education. Medical treatment in Japan had been mainly home-based, but the creation of hospitals, which were becoming the norm in Europe at the time, was due to Pompey's efforts. Some of those medical students moved to private schools like Juntendo and further spread the knowledge gained from Pompey. The nurturing of those who would form the foundation for medical education and medical administration under the newly emerging social system began. After a large-scale civil war in 1868, known as the Boshin War, Japan transitioned to a modern centralized system. This reform gave rise to new issues. An increase in injured and sick soldiers from the Civil War. An epidemic of infectious diseases like cholera and measles, resulting from interaction with foreign countries. Kanto failed to treat either of these. The new Meiji government decided to change Japan's medical care to Western medicine, replacing Kanto. Their first step was to start reforming medical education. Within just 2 years of the establishment of the new government, Daigaku Toko was established to teach Western medicine as one of the national educational institutions. A decision was made to learn medicine from Germany, which excelled in the field, and medical education was conducted in German by guest German instructors. Graduates who had studied in Germany also returned home and became instructors, and high-quality medical education was commenced as part of national policy. Securing an adequate quantity of domestic medical care was also an urgent matter. The first step was for previously practicing doctors, including doctors of Chinese medicine, to register and be allowed to continue as doctors. The medical practice examination commenced in 1876, and this opened up the path to becoming a doctor through examinations. Additionally, nearly all prefectures throughout Japan established public medical schools and hospitals. Along with preparatory education for the medical practice examination, medical schools provided education in Western medicine for medical practitioners, which had begun in the Edo period. This was the start of efforts to achieve modern medical care of the highest possible quality at the national level. Modern medical education had finally started throughout Japan. However, like the newly formed government, this system also faced a great deal of confusion and turmoil. The general rule for medical schools was announced in 1882. All medical schools were designated as either Type A or Type B. Type A schools could confer medical qualifications on medical school graduates without examinations, conditional upon employing at least 3 teaching staff with medical degrees, or in other words, graduates of Tokyo University's School of Medicine. This policy, which supported the training of doctors at regional medical schools, became a burden on the medical schools. It was extremely expensive to employ staff with medical degrees from such a small elite group, which even strained regional finances. This resulted in the closure of many public medical schools. Private medical schools emerged during this time. Though students were required to sit for the medical practice examination after graduation to obtain the qualifications of a physician, these schools attracted many students. In 1900, Tokyo Women's Medical School was established as a medical education institution exclusively for women. However, the quality of medical education also had to be improved in line with the development of modern medicine. The Vocational College Order was enacted in 1903 to solve such issues. Private medical schools were required to meet defined standards and to obtain national accreditation. On the other hand, medical matters were also at the mercy of political affairs, and Saisei Gakusha, a prominent private medical school, was forced to close due to political conflict. Then, in 1916, the University Order was enacted. Under this order, numerous national, public, and private medical vocational colleges qualified as universities for high-level medical research. In this way, Japan's medical education appeared to be substantial, both in quality and quantity. But it faced significant problems. In 1923, the capital Tokyo was struck by the Great Kanto earthquake, the largest earthquake in history at the time. The death toll exceeded 100,000 people, and almost 300,000 homes were destroyed or burned. What became clear through this unprecedented disaster were the poor clinical skills of doctors who were helping the injured, and the fact that their numbers were still insufficient. In response, a succession of private medical vocational colleges was established and accredited with the aim of training doctors with clinical competence. During this era, Japan's medical education system changed rapidly.
医師の教育を大学でやるべきなのか、専門学校でやるべきなのかというやっぱり論争がありました。ところがその一方で関東大震災での実践的な医療の必要性というものがやっぱり必要だということも理解されて、そうすると、特に私立の医学校は大学ではなく専門学校として 実践的な医者を育てていこうとする。その時代その時代のニーズに合わせて、高度な医療も一方では追求し、もう一方では幅広く多くの人たちに医療を提供する、サービスを提供するということも追求し、その、両方を追求するという形を、どのように実現していくか。戦前の日本はそれを医科大学と医学専門学校という形で実現していたということになるわけです。
Having weathered a variety of difficulties, medical education in Japan started coming together. However, the path to war that Japan had itself been treading shook Japan's medical care to its core. The war that had started in 1937 gradually expanded in scope. Many doctors were called up as military physicians, and an increase in doctor numbers was requested. In response, more medical education institutions were established, both public and private. In addition, the education period for doctors, pharmacists, and nurses was greatly shortened. The unreasonable push to increase numbers resulted in a significant decrease in the quality of medical care. Further, as most male doctors were sent to the front as military physicians overseas, female doctors bore the burden of domestic medical care. Medical vocational colleges were established in various regions to compensate for the ongoing inadequacies of medical care. When the war ended with Japan's defeat in 1945, both the quality and quantity of medical care and public health within Japan had totally changed. By conceding defeat in the war, Japan came under the occupation of the Allied powers, led by the United States. Though until then, the foreign language used in medical education had been mainly German, a change to English was requested, and the curriculum was also changed to match that of the United States. Medical research had developed significantly in the US and Britain during the war. The majority of students from Japan studying abroad headed to the United States. Moreover, the three types of medical schools that had existed, including the School of Medicine of the Imperial University, medical universities, and medical vocational colleges, were all unified to become universities under the new education system. The previously shortened years of study were lengthened to 6 years before graduation, and students were required to pass the National Medical Practitioners Qualifying Examination after completing the newly introduced internship. The medical internship system was one of the aspects incorporated from the American medical education system. The aim was to thoroughly train doctors who have acquired clinical skills through on-the-job training. However, this internship system caused major turmoil within medical education. A student movement arose in 1967 seeking to abolish the system, and 80% of students boycotted the National Medical Practitioners Qualifying Examination. And in 1968, the internship system that had lasted for over 20 years was abolished. A residency system commenced where students would sit the National Medical Practitioners Qualifying Examination immediately after graduating from a medical faculty. Then, after obtaining their medical license, undertake at least 2 years of clinical training. This finally became the medical education system that survives to this day. At the same time, the medical insurance system was also expanded. By attaining universal health insurance coverage in 1961, people such as the self-employed and agricultural workers who had previously not been covered by health insurance became eligible to receive the necessary medical care at a fixed co-payment rate. This system further increased demand for medical care. Increased student capacity at medical universities and the rapid building of new national and private medical universities led Japan to finally acquire the necessary quality and quantity of medical care and achieve UHC.
それぞれの国にはそれぞれ歴史があり社会があります。そして医学医療というのはその一方でユニバーサル普遍的なものです。でその普遍的な医学は国民に健康と生命を守るための医学医療を提供するということがミッションです。しかしそのミッションを実現するためには単に医学医療を持ち込むだけではなくて、その国情に合わせて試行錯誤で作り上げていくものではなくに違いないと思います。ただその試行錯誤は必ず達成できるものです。それを日本の医学教育の歴史は教えてくれると思います。
At first glance, Japan has a well-formed medical education system and educational institutions and no apparent problems with maintaining UHC. But new issues are already surfacing. Many countries face the challenge of a decreasing birth rate and an aging population. About 30% of Japan's population is over age 65. This is estimated to reach nearly 40% by 2060. Conversely, the birth rate is declining. While the demand for medical care is increasing, the number of medical personnel is expected to decrease. Further, since the 1970s, medical science has advanced rapidly, and experts with high-level medical care skills and mastery of medical equipment have come to conduct their medical practice within their separate specialized fields. Currently, there are more than 22 types of medical professions with national qualifications. In medical treatment settings, doctors are expected to play a central role among such specialists and to have coordinating skills as a team treatment leader. Initiatives have commenced to achieve new quality medical education to compensate for the expected shortage of doctor quantity. The biggest reforms since the immediate post-war reforms include the Medical Education Model Core Curriculum, implemented in 2004. This indicates achievement goals for the 6 years of medical education, created by the Common Achievement Tests organization, in which medical universities nationwide participate. The curriculum specifically lists general goals and achievement goals for overall knowledge, skills, and attitude that should be acquired by university graduation. Another reform was a new clinical training system. Clinical training, which was previously not compulsory, was made mandatory, and long-standing clinical training system issues were improved. The initial clinical training now included content to enable acquisition of primary care capability, an understanding of sociability as a doctor, and character building. It also assured the salary of clinical trainees. This was the start of medical education with practical skills to meet the needs of today's patients.
もはやね、医学は医学だけでは成り立たないんですね。国の支援があって、社会の支援があって、そして社会とともに、進んでいく医学、それがこれからの医学医療だと思います。医師を養成する医学教育も単に医学医療を学ぶだけではなく、そしてさらに新しい医学を作り上げていくという課題も必要ですし、社会の 理解を得るためのコミュニケーション、そして合意を得ていくためのコンセンサスを形成する力、そういった力を養うこともこれからの医学教育に求められていくのではないでしょうか。
It took many years to achieve UHC in Japan. In modern times, what is required for the early achievement of UHC in various countries around the world? The Japan International Cooperation Agency, JICA, has cooperated in health and medical fields in over 150 countries globally as part of official development assistance to support the achievement of UHC. Mongolia is one such country aiming to promote UHC with cooperation from Japan. Although the number of doctors nationally was not necessarily inadequate, they were concentrated in the capital of Ulaanbaatar. There was a conspicuous variation in the quality of doctors' skills, and particularly in the outlying regions, major improvements in medical care quality and quantity were needed.
2010 оны үед бол Улаанбаатар хотын лаврагат төвөөрөлд 2-3 эмнэлэг дээр бүх резидентийн нарийн мэргэжлийн сургалтууд бол бүгд явагддаг байсан. Тухайн үед резидентүүд бол яг тэр хичээл одоо заалгаж байгаа багш эмчийнхээ туслах маягаар ажилладаг байсан. За ингээд яг одоо энэ улсууд тэр нарийн мэргэжлэр төгсөөд ирэхэд бол хангалттай хэмжээний мэдлэг, дадлаг чадварыг бол эзэмшээгүй байх. Ийм тохиолдол бол гардаг байсан шүү.
Mongolia sought assistance from Japan to overcome this situation.
地域で医療人材を育てるようにしてほしいと。でかつちゃんと質の担保された、かつ国民のニーズに合った医療人材を育てるような制度作りをしてほしいという要請があり、それに対して私たち技術支援を行うことになった。
The first phase of the project has already been completed, and expectations are high for future development.
Бас сувилагч нарын мэргэжил дээшлүүлэх, олгох энэ сургалтуудыг эдгээр байгууллагуудад түшиглээд хийвэл илүү үр дүнтэй болно.
The project to strengthen postgraduate training in Mongolia started in 2015. The preparatory survey revealed that there were some similarities between problems faced by medical care in Mongolia and those in Japan.
医師の育成するカリキュラムだとか医師の育成する制度ですねが十分に質を担保するものにできていなかったということもあり、卒業したばかりの人たちが十分な能力を身につけないままそのままずっと医師としてのキャリアを過ごしていくという状況が生まれていました。モンゴルも非常に優秀な先生方はたくさんおられます。で、ただですね、特定の領域にものすごくその能力のある方たちであって、非常に基盤が脆いというか、あと本当に一般的な、よくある病気の方たちを見る人たちの質というのがちょっと今一つ、安心できない国民が感じ取られたそのもの事実かなというふうには思います。
In addition to the inconsistent quality of doctors, another issue that Japan had faced and has been resolving is an increase in chronic illnesses, such as diseases resulting from changes in lifestyle. We determined that we could effectively utilize Japan's past experience. Based on this survey, we designed a training system to suit Mongolia's circumstances, modeled on the postgraduate clinical training system that was introduced to Japan in 2004. In addition, the curriculum that Japan later introduced in 2020 was introduced to Mongolia ahead of Japan. Actual operations started from 2018, using the Regional Diagnostic Treatment Center in Orhon Province as an advanced model.
私たちのプロジェクトで関わった研修の一番の大きな違いというのは、その内容を 国が定めで、カリキュラムとか指導者というものをちゃんと質を担保した形にしたというのが一つ大きな違いです。モンゴルでは総合診療研修という名前で呼ばれていますけれども、大学を卒業した1年間を直後ですね、1年間をかけてこれからの医師としてのキャリアを積んでいく過程で基礎となるような勉強をしましょうということにしています。なので地域の病院で1年間をかけて内科、小児科、産婦人科、救急科と1年間のローテーション研修を組んだというところが、実はこれまで私たちが始めるまでモンゴルにはなかった研修のスタイルになります。
The method used, which was modeled after Japan's, had never existed in Mongolia. It involved supervising doctors and trainees communicating closely, and trainees acquiring practical diagnostic skills through teamwork. Some Mongolian trainers participating in the project expressed concerns.
で実際このプロジェクトを始める前は、やはりその病院の指導医の先生方はものすごく不安に感じておられました。その指導者というものがすごくできるスーパーな医者がなるものだというふうに思っておられて、不安を感じておられた先生方が大きく変わった、ターニングポイントになったことがありまして、それが日本への本邦研修に出かけたことなんですね。で、指導医が特にものすごくスーパーなことをしているわけではなくて、日々の診療の中でベッドサイドで研修医たちに指導している。で、研修医たちとディスカッションしながら双方向で共に学んでいる。つまり研修医だけが学んでいるのではなくて、指導医も一緒に研修医と学んでいる、その姿を見られて、帰ってきてから皆さんすごく変わったんですね。で、何よりもやっぱり自分たちにもできるんじゃないかという気持ちを持たれたのが一番大きいんではないかと思います。
Бид нэр Японд очоод Токио хотын имлгүүд, за Ивата мужийн төвийн имлэг, за Тоба гэдээ бас суурин газрын жижиг имлгүүдээр орж тэнд ажиллаж байгаа резидентүүд, суралцж байгаа резидент эмчнэрийн байр байдал, за багш нартай нь бас нэлээд сайн танилцж, газар дээр нь танилцсан. За ингээд ер нь энэ сургалт төр нь яг ямар зарчмаар явагдгийг. За оюутнууд маань бас резидентүүд маань бас яг ямар байдал, нөхцөл байдлыг бас суралтын гэдгийг бол нүдээр харсан учраас ирээд энэ сургалтыг бол орон нутагтаа хийх бүрэн боломж байгаа юм байна. Бид нар энийг бол хийж чаднаа гэсэн тийм итгэл найдвар төрсөн.
The project for strengthening postgraduate training for health professionals in Mongolia started with the Regional Diagnostic Treatment Center in Orkhon Province as an advanced model. Upon completion at the end of 2020, a number of hospitals that had established systems as training hospitals applied for accreditation. The fruits of this project are spreading throughout the country. From 2021, an initiative targeting nurse training will commence as part of the second phase of the project.
この国で、UHC の達成というのは十分可能だと。で、そのポテンシャルを持っている、国だというふうに思います。で、モンゴの方たちというのは自分たちの国を良くするということに対してすごく熱意を持っている方たちですね。愛国心がある方たちで、本当に自分たちの力でこの国全体を良くしていくと、医療の質を良くしていくということは十分可能だというふうに私は思っています。
The importance of UHC, universal health coverage, is now acknowledged by many countries globally. In partnership with developing countries, JICA aims to support the realization of UHC all over the world.